So we'll go ahead and get started. I want to welcome you to Persist Grand Rounds, an online series of lectures hosted by Persist covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. My name is Marie Terrell, and I am the Director of Product Management with Persist, here to introduce our speaker and topic for today's Persist Grand Rounds. Next slide, please. One before that, actually. That one. Yep, great. So through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persist Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community, to share their expertise and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. You can visit persist.com/grandrounds to keep up to date with the schedule. All right, next slide. So the opinions and viewpoints of each speaker are solely their own and do not represent Persist or any other commercial entity or commercial interest. Speakers are not required to include Persist, its software, products, or services. The content presented was not prepared or edited by Persist. Persist is not providing any form of compensation. And last slide. All right, and now I would like to introduce to you our speaker for today, Dr. Charles Casassa. Charles is Assistant Professor of Neurology within the Division of Epilepsy and Clinical Neurophysiology at Loma Linda University Medical Center. He will be speaking today on the topic of quantitative EEG applications for seizure detection from neurophysiologists to nurses. The learning objectives: first, to identify the key quantitative EEG trends commonly used for seizure detection and understand their relationship to raw EEG. 2, describe potential applications of quantitative EEG as a screening tool for seizure detection to be used by non-neurophysiologists. 3, understand the limitations of quantitative EEG protocols for seizure detection and areas in need of further research. And a little bit about Dr. Casassa before we launch into this. He attended medical school at Georgetown University School of Medicine. He then went on to complete his residency in neurology and a fellowship in clinical neurophysiology, both at Beth Israel Deaconess Medical Center. Dr. Casassa is board certified in neurology and clinical neurophysiology. His research interests are in the use of seizure diaries as a tool for clinical research and practice, improving access to care for those with epilepsy, and the application of EEG in the ICU. So there will be time for questions afterwards. And meanwhile, if you looked at the very bottom of your screen, you can see a Q&A button. Please click that and type your question in, and we will be able to address it at the end. This webinar is being recorded, and a copy of the recording will be made available to all participants afterwards. And now, without further ado, I present to you Dr. Casassa.
Thank you so much for having me. Really appreciate it. So I'm going to talk today focused on seizure detection. As we all know, there's multiple different modalities and uses of quantitative EEG, but I'm really today going to be focused on seizure detection and what algorithms are out there, how you can approach it clinically, and including info not just for neurophysiologists, but nurses, EEG techs as well, all of which can have advantages. So for a background, I'm going to, for the outline, I'm going to start with the background about quantitative EEG, and then I'm going to walk you through several selected components that are most useful for seizure detection in quantitative EEG, including automated seizure detection, the seizure detection algorithms, the color density spectral array, also sometimes referred to as CDSA, also can be referred to as the fast Fourier transform or FFT spectrogram, the rhythmicity spectrogram, the asymmetry spectrogram, and then I'll finish with a brief discussion about potential applications for non-neurophysiologists and limitations of future directions. So just for to begin the talk with a couple brief background slides. The talk today is about quantitative EEG, but just to keep in mind that review of the continuous video EEG or raw EEG remains the gold standard for seizure detection. So really the quantitative EEG is best reviewed in conjunction with the raw EEG. With that being said, continuous video EEG has some limitations. It's time consuming to review a lot of information, especially if you have many 24-hour studies to review in a given morning. It can be difficult to respond to raw EEG in real time. So if it's middle of the night, 2 or 3 a.m. in the ICU, you're not going to maybe be able to dedicate the same amount of attention as you would in the daytime. And then also overnight and remote access can be challenging. So while raw EEG is still our gold standard, it does have some challenges with it. And thus emerged quantitative EEG, which allows us to review larger amounts of data in a compressed time scale. So you can review up to, say 2 hours of data with a single screenshot, which we'll show in just a minute. And it has many different applications besides just seizure detection, including detection of cerebral ischemia, post-cardiac arrest prognostication, status epilepticus detection and management. And there have been multiple previous Persis Grand Round talks on these topics. A big limitation that's commonly cited of quantitative EEG is false positive detections. So that's something that we'll talk about later. And really the highlight is we need to review it in conjunction with, not exclusive to, the raw EEG. The basis for quantitative EEG is what's referred to as the fast Fourier transform. The idea for this being very simplified is that the EEG signal that we see on the page, it's not just a single frequency. Like we're not seeing just alpha frequencies or just theta or just delta frequencies. The signal that we see is complex and represents a summation of multiple frequencies. So really what the FFT is trying to do is to transform this, breaking down this signal that we see into its component frequencies. So for example, if you have a signal that's say mostly delta, a little bit of alpha and a little bit of theta, expressing each of those frequencies and the power represented by each of those frequencies. And we can measure the power of the frequency band in a graphical form via a spectrogram, which I'll show in just a minute, where the x-axis is time, the y-axis is frequency, and the z-axis is power, which can be measured by different colors. So this is just a show from a great textbook that an example of what we're looking at. So the bottom is an EEG signal, which includes multiple different frequencies. And what you are doing is you are breaking down that signal to different frequencies. So the slower frequency would be this color, the faster frequency would be the blue, and then you can plot the power of these different frequencies, i.e., kind of how much of each of those frequencies are there in this signal in graphical form. So on the x-axis here is going to be time, and on the y-axis is frequency. So the lower frequencies would be towards the bottom. Say this signal here would be towards the bottom. The higher frequencies are towards the top. So this y-axis goes from 2 to 20 hertz. And you can express the power of each of those frequencies by color. So red, for example, would be higher power and blue would be lower power. So you can reflect that here. So for example, if you see red at 2 hertz here, that indicates there's a higher power of 2 hertz activity. So there's many different components to quantitative EEG. We're going to review a few of the more selected ones that I found most helpful for seizure detection and the ones that have the most data published in the literature about it today. Just know that there are other really helpful things such as alpha delta ratios and suppression ratios, et cetera. So if I take an example here, this is an example of a normal raw EEG where you see a really nice anterior to posterior gradients. You see a nice posterior dominant rhythm in the posterior region. What if you were to take this signal and express it in a quantitative EEG, it would look like this. So just to break it down real quick, we have on the most important things I want to draw your attention to are seizure probability and seizure detections up here at the top. So PERSIST has an option where if you have a seizure detection, it will show up here. It'll be a red band here, but it can also express as a probability from 0 to 100% on this y-axis. But jumping down here, we have the rhythmicity spectrogram, which is always the way it's displayed is left over right. So we have the rhythmicity spectrogram of the left hemisphere here, and below that, the right hemisphere. Finally, below that, we have the FFT spectrogram. The top is the left hemisphere, and the bottom is the right hemisphere. And one thing that you'll see is that there is in the FFT, if you notice here, there is a red band here about halfway through halfway up the y-axis, both on the left hemisphere and the right hemisphere, and that is red. That is indicative of 10 hertz frequency because the y-axis here goes from 0 to 20 hertz. What you see is that there's a nice red band here at 10 hertz, which if you refer to this key here of the power, which is your z-axis here, the red and the pinks towards the right reflects higher power. The black and the blue towards the left reflects lower power. You see that this red here reflects a higher power of alpha frequencies, which is reflected in the EEG that we just saw, where you see predominantly alpha frequency activity at 10 hertz. You also see in the rhythmicity spectrogram the same thing. Y-axis from the y-axis is frequency. This one goes from 1 to 25 hertz. You can see about halfway through at 10 hertz, there's a darker band here, a darker color here, again, reflective of higher power in the rhythmicity spectrogram, showing that it's actually picking up this posterior dominant rhythm here, that rhythmic alpha activity here on the rhythmicity. So to summarize, basically, when you're looking at this, it's going to be left hemisphere or right hemisphere, and the rhythmicity spectrogram is measuring rhythmicity, the power of rhythmicity at certain frequencies, and the FFT is measuring the power or the presence of each of those component frequencies of the signal. So now we're going to talk about the different algorithms for seizure detection. So the first is the one that I think many of us are most familiar with, which is automated seizure detection. Those are going to be the algorithms that will just show up as you're reading EEG if it's superimposed on the raw EEG you're reading, seizure detected. And there's multiple available. There's some from PERSIST, some from VEDAS, for example. And what all of these detections basically do is if you think about the definition of electrographic seizure, which shows evolution in multiple modalities, rhythmicity, evolution in spatial temporally, rhythmicity, frequency, et cetera. It's essentially evaluating the scalp EEG signal for a change in the background that shows these multiple components, rhythmicity, evolution, amplitude, or frequency, et cetera. And it's coming up with an output, is it a seizure or not. It's based on, these algorithms are based on machine learning training, which can come from multiple different populations. For example, algorithms built on adult or pediatric populations or EMU or ICU populations. And they're most useful for seizures that have a clear pattern of spatial temporal spread. So that's what I refer to it kind of as most helpful for the classic seizures, which show evolution in multiple modalities. So it can be helpful for seizure quantification as well. Say you have somebody who's in status epilepticus and you want to quantify how many seizures they have per hour. You can do that very easy. So it is pretty effective in that it's overall good. The sensitivities of just the automated seizure detection in isolation are somewhat variable. Studies range from the lowest I've seen has been the sensitivity of about 37%, highest being 92%. Of course, all these studies are mostly retrospective and they focus on different populations. So, for example, studies 2 and 3 here did show higher sensitivities, but were not we're focused on the pediatric and adult population, whereas the study 1 here is focused on the pediatric and ICU population. But this is just automated seizure detection sensitivity and isolation. One caveat to automated seizure detection algorithms themselves is that the presence of periodic discharge of periodic patterns does somewhat reduce its reliability. So this was a really interesting study that looked at 98 routine and LTM long-term monitoring studies of all ages that were selected for the presence of periodic patterns and or seizures. So it was these studies were retrospectively selected, and essentially what they did was they divided the patients into 4 groups. Group 1 was the presence of both patients who had both periodic patterns and seizures. Group 2 had periodic patterns but no seizures. Group 3 had no periodic patterns but did have seizures, and Group 4 had neither seizures nor periodic patterns. And essentially what they did was the study group included 2 neurophysiologists who were reviewing persist seizure detections in conjunction with either the seizure detections in and of themselves or the seizure detections plus other modalities like rhythmicity or FFT. And they compared this to the gold standard of raw EEG interpretation by 2 neurophysiologists. So what they found was that the seizure was detected by the algorithm in 76% of cases, which is pretty good compared to the gold standard. However, when you looked at the subgroups, there was a lower PPA, which is their term for positive percent agreement, essentially same as sensitivity, lower sensitivity and a higher false positive rate in the subgroups who had periodic patterns. So if you look at this here, groups A and B, these top 2 had periodic patterns. Group C and D, the bottom 2, did not have periodic patterns. And what you see is there's a wider range for the false positive rates in the groups of periodic patterns, as well as a slightly lower sensitivity, 75% compared to 100% in the groups that did have periodic patterns. So the take-home message there is that periodic discharges can kind of challenge things. So that's when you really want to make sure you look at other components of the quantitative EEGs. So here's an example of where I think the automated seizure detection is really helpful. Again, it's used for more of the classic cases. This is a patient who had a right anterior temporal cavernous malformation, came to the EMU for pre-surgical evaluation. And you see here, looking at the raw EEG, so this particular montage has all the left hemispheric channels over all the right hemispheric channels. So you have a left temporal chain, left parasagittal chain, midline, going from top to bottom. North from top to bottom, we have left temporal chain, left parasagittal chain, midline, right parasagittal, right temporal. And you'll see here, you start to see rhythmic, sharply contoured 5 to 6 hertz activity at F8 T4. Paging through the seizure, you see it evolve in terms of frequency and spatial spread becoming about in the 5 hertz range, and then gradually slowing to the delta range until the seizure ends. So to summarize, we saw the seizure start in the right temporal region, starting with the 5 to 6 hertz activity that evolved in rhythmicity and slowed to 1 to 2 hertz. So you see that seizure expressed on the quantitative EEG. You see it's detected with these bands here for seizure probability and seizure detection. To jump down to the rhythmicity spectrogram, you can see here that there is rhythmicity building at about the 5 to 6 hertz frequency band initially. And then as the seizure develops, remember the x-axis is time, you see that dark band of rhythmicity moving down to lower frequencies, moving from 5 to 6 hertz, strong power rhythmicity down to 1 to 2 hertz towards the end. And that's a really nice example of evolution of frequency. Some people might say that you call this like a step down. That can be one pattern that you see on the rhythmicity spectrogram. Same thing with the FFT. You see strong red and pink colors initially at 5 to 6 hertz that gradually go down to 1 to 2 hertz, reflective of that change in power. And we haven't really talked much about asymmetry spectrogram, but you can also see in the asymmetry spectrogram that it's noting a higher degree of power asymmetry on the right. So what the asymmetry spectrogram looks at is the power of certain frequencies at homologous electrode, left and right. And red is reflective of higher power difference on the right. Blue is reflective of higher power difference on the left. So with this seizure, you see it kind of checks all the boxes. It has evolution on the rhythmicity, on the FFT, on the asymmetry. Those are going to be the best cases that this seizure detection algorithm at the top is good for picking up on. Another example, just to kind of bring home that message, is a patient who we saw who was stuporous after an altercation with a head strike. He had multiple electrographic seizures that were characterized by low voltage fast activity at T602 that spread throughout the right hemisphere. So how it started is if you look at the EEG from the baseline, unfortunately the edge of the EEG got cut off here on the screen, but towards the right, there was supposed to be rhythmic alpha activity there at T4, T6. You see that here, which continues to evolve throughout the right hemisphere. As the seizure goes on, you see it slows from the alpha frequency activity to more like 3 to 4 hertz activity, and it continues until it ends. So same thing. This is the kind of seizure that would be really helpful for detection with the standard seizure detection algorithm, because you see that there is a really nice evolution in frequency going from up here. This is your alpha frequency band up here. As you see the seizure progresses, it decreases to the theta and delta range. So this low voltage fast activity then spreads over time to the theta and delta evolution. The stars show that later in the seizure, we can see that there's more higher power bands of red and pink colors, lower frequency. And then the circle shows that we see the more degree of power asymmetry and homologous electrodes to the right. So both of those examples I showed you are kind of more classic seizures that are really well detected with that kind of algorithm. This is really helpful because for this particular patient, once we saw that initial seizure pattern, we can quantify the seizures. So in this 2-hour epoch, you can see that there were several seizures per hour, and they all kind of had that same pattern, almost looks like a wave or a step down pattern. And then it allows you to figure out how you're doing with treatment. So in this case, patient initially was loaded with some seizure medicine. This is the follow-up persist EEG view. And then the seizure stopped, we see so we can see really that nice pattern of the treatment response once we know that initial EEG pattern and the signature pattern of the seizure. So now just to change to focus, instead of just seizure detection algorithms, to just looking at the rhythmicity spectrogram, that's useful for capturing seizures that have evolution in frequency over time, as you might imagine. Some studies have shown that it's more useful for focal seizures that have secondary generalization. So, for example, one study looked at if you were to just look at the rhythmicity spectrogram in isolation, it had a 48% sensitivity. However, when you focused on focal seizures with secondary generalization, it increased that to 65%. So, again, in practice, you're going to be looking at multiple modalities at the same time. But I just wanted to kind of focus on each of these components to show you what kinds of EEG patterns they're really helpful for picking up. So here's an example of a patient who came in, who has a background in epilepsy, came in with the acute decline of mental status in the setting of sepsis. His initial EEG just showed diffuse background suppression. And we see here that kind of fairly broadly throughout the left hemisphere. I should orient you briefly. This montage is left. The top is going to be left paracentral, then it's going to be right paracentral, left temporal, and right temporal. So your standard bipolar montage. You see that fairly broadly throughout the left hemisphere is this burst of rhythmic alpha activity, which continues and then suddenly stops. And then that's followed by return to the suppressed background. On this, you'll notice that unlike the previous seizures I showed you, the seizure probability and seizure detection bands up here are not lighting up like a Christmas tree because they did not pick up the seizure. It was best picked up with the rhythmicity spectrogram, which showed that over here you see this really nice darker colored rhythmic activity picked up at about 10 hertz. Again, remembering that the y-axis goes from 1 to 25 hertz, a really nice activity there. And you can see, even though it's not really the focus of the talk today, it is picked up on the amplitude integrated EEG as well. But this is an example of a seizure that really is only picked up with the rhythmicity spectrogram. You can further break it down by rhythmicity by channel. So you can, if you look at, for example, FP1, F3, C3, P3, F3, C3, those are where you're going to see some of your highest rhythmicity band detections there. And notably, this was seen actually in this particular patient, the seizure ended up being quite refractory to treatment. And later on, the seizure detection algorithm were able to pick it up. But all these changes were seen before the seizure detection algorithm. So a few hours later, again, you can kind of, once you know that EEG signature pattern, you can see it changing over time. And here you can see seizure, 3 seizures on this page that are later detected here with the seizure detection. And you can assess the response to treatment. So in this patient, after he was treated, you see the EEG go back to the suppressed background. Unfortunately, once anesthetics were weaned off, you can see that on the quantitative EEG that you start to see some of this rhythmic activity start to come back, in addition to other activity at the FFT where we're no longer seeing the diffuse suppression, and these are when the seizures came back. And these were the seizures that we saw, which were associated with right-sided twitching. So that we've talked about seizure detection algorithm. We've talked about rhythmicity. Now to look at the asymmetry spectrogram. The asymmetry spectrogram, as we briefly discussed, looks at a relative comparison of power among homologous electrode pairs for each frequency domain over time. Again, I saw on one of the intro videos on persistence says it's like America's political system. where blue color reflects higher degree of power asymmetry in the left hemisphere. Red indicates higher power asymmetry in the right hemisphere. And the asymmetry spectrogram is really useful for focal seizures, which may be isolated just to one particular hemisphere or one particular region of the brain. There's an example. This is a patient who has a background of autoimmune encephalitis with epilepsy, came in with suspected focal status epilepticus in the setting of a febrile illness. And I'm looking at his seizures were kind of best seen in a transverse montage. So just to briefly orient you to the raw EEG, we have on the top, we have the midline and left frontal region. Then we have so FZ, F3, et cetera on the top. Then we have the more central regions beneath that. And finally, EZ, E4 on the bottom. So what we see here is it's a little messy. It's not very clean, but you can see that there is this rhythmic mixed frequency activity at FZ, F3, which paging through the seizure evolved, and predominantly the kind of theta delta borderline over that left frontal region. And it just continues paging through the seizure, eventually slowing down. So what the quantitative EEG trend looked like for this? Well, again, you don't really see the seizure detection light up on the top. The rhythmicity, yes, you see some rhythmicity there at 5 to 6 hertz. That's reflected with the star here on the left hemisphere, but it doesn't really stand out too much. Like I can imagine if I were to be paging through this EEG in 2-hour epochs, I could easily miss it if I was just looking at that. Same thing with the FFT. It really shows up nicely in this asymmetry spectrogram here, where you see that higher power of blue among different frequencies, and reflective of that difference in power for homologous electrodes in the left hemisphere. And for this patient, that ended up being a really nice pattern for his seizures that were detected. So putting it all together, the key principle is incorporate multiple quantitative EEG modalities when you're looking at it for seizure detection. Don't just rely on the seizure detection algorithm alone. That's not enough. In particular, you're going to have increased sensitivity for detecting focal seizures when using other modalities. And again, as we discussed, the asymmetry may be better for focal seizures. The FFT may be best for focal seizures with secondary generalization. And the seizure detection algorithm, studies have shown that it's best for generalized seizures or seizures that kind of check multiple different boxes with evolution in rhythmicity, spatiotemporally, et cetera. So just to shift gears here for the last part of the talk, we're going to be discussing how might you apply these principles for non-neurophysiologists. And so there have been some studies looking at this in the literature, which have looked at different people using quantitative EEG, including nurses, residents, fellows, EEG techs. One can imagine that it has a lot of advantages, right? Because one is real-time responses. So if you have a nurse at the bedside who is trained and knows what they're looking for in the quantitative EEG, maybe they could detect seizures earlier and notify the appropriate parties. It may allow for earlier detection of non-convulsive status, and it may be just a helpful screening tool. Of course, the big asterisk is that the disadvantage would require training, supervisory issues to making sure that the non-experts know what they're looking for and are properly trained about that. The studies that have looked at this in the literature actually have shown very good sensitivity, ranging from about 74 to 96% in terms of seizure detection. But the false positive rates can be, as you might imagine, variable and can be quite high, ranging up to 3 per hour. The studies that have been published have looked at either the color density spectral array, or FFT, alone, or using multiple modalities. And a big asterisk is that these studies that have looked at non-experts are largely, except for one, which I'll show you, is limited to retrospective studies. So EEGs that have already been done, and then having the non-experts go back and review those in comparison to a raw EEG. So this was a really excellent paper by Krista Swisher and Kalem out of Duke. And it looked at this from their review article, looks at the different few EEG studies that have been produced, this is looking at non-experts. And just to orient you with what it's looking at is it plots all these studies in terms of on the y-axis sensitivity. So this top block looks at sensitivity going from 20 up to 100%. The bottom box looks at the false alarm rate with higher numbers towards the bottom here. And on the x-axis, it's looking at different trends that have been studied. So amplitude integrated EEG, automated seizure detection, color density spectral array or FFT spectrogram, and a combination. And you can see that there's a good amount of variability, but generally speaking, the sensitivity is pretty good and the false alarm rate is somewhat variable. So the one prospective study, the same Krista Swisher also led a prospective study that looked at the only study that I'm aware of, which basically had trained nurses in terms of how to detect, how to look at a person's seizure pattern from the raw EEG to the quantitative EEG, and then actually prospectively following that. So essentially, what they did was they enrolled nurses after a patient already had a seizure or continuous EEG. So the neurophysiologist determined that the person had a seizure, then they trained that nurse on, okay, this is what the seizure looks like on quantitative EEG with the rhythmicity spectrogram and the amplitude integrated EEG, and basically had tailored education of the quantitative EEG for that particular patient. So it was very individualized. And what they did was they had the nurses review the quantitative EEG hourly, and they compared it to the gold standard, which, as we all know, is looking at the continuous video EEG reading, so the raw EEG by 2 neurophysiologists. And it was a very, very small group. It was only 20 patients, but they had 174 hours of data. And they found a sensitivity of 85% and a specificity of 89.8%. The false positive rate was not as high as one might expect. It was only 0.1 per hour. And they also found that hemispheric seizures were, so like more kind of broad field seizures were improved compared to had better sensitivity compared to more focal seizures. So overall, putting it together, I think it shows promise as a potentially a high sensitivity, low false positive rate with individualized training. So that's the big asterisk, is that these nurses were really trained in terms of what to look for each individual patient, which of course requires time and resources. And also, again, the asterisk that this study, even though it was prospective, was looking at patients who already had a seizure detected. But it showed a lot of promise, I think, for the future. So just to finish up in the last few minutes here with some limitations. So there's definitely limitations to quantitative EEG for seizure detection. The studies have shown that it seems to have most difficulty if seizures have several characteristics. So more difficulty with low amplitude, slowly evolving seizures, seizures that have evolved over a smaller spatial region and are short duration. So one study looked at that among missed seizures, most missed seizures met one or more of these criteria: voltage under 75 microvolts, duration under 1 minute, isolated focal, or had abundant interictal epileptiform discharges, which kind of gets at one of the earlier points I made in this talk, which is that seizure detections are not as great for patients who have kind of a messy EEG background with lots of periodic patterns or interictal activity. Another limitation of quantitative EEG is that it has a can have a high false alarm rate, so which can lead to a risk of alarm fatigue. There are some different approaches to this, like when you're looking at it, there's different artifact reduction techniques that can be used and such. But it does have a risk of alarm fatigue if it's picking up too many false detections. And there's also a lot of the studies have looked at either mixed populations or pediatric populations, or EMU, ICU. There probably need to have more studies looking at seizure detection algorithms in adults only, especially in the ICU population. So this is, even though PERSIST is not, or quantitative EEG is not really yet validated for patients under, at least traditional quantitative EEG, under 2 years of age. This is one paper in the literature which showed a seizure here over the left hemisphere that was not really well detected with color density spectral array, or FFT. So it was kind of a very, very slowly evolving seizure isolated to one region. So those are going to be the kind of seizures that you may be able to miss. Interestingly, of course, if you incorporated just the amplitude EEG part of it, you could find these subtle brief elevations of the baseline correlating with the seizures. But still, it's the take-home message is that these kind of slowly evolving seizures that are isolated to one area. So to put it all together, I think quantitative EEG is helpful, time-saving screening tool for seizure detection. Know that each patient is different and don't rely on any one modality. And the way I always tell residents and fellows is kind of know the EEG signature for each patient. And then that kind of gives you a marker for what to refer to as you review the EEG later. It must be reviewed in conjunction with the raw EEG. I can't emphasize that enough. You can't really look at them in terms of an isolation, quantitative versus raw EEG. It's really looking at them together. We talked about some seizures that may be missed with it. And finally, it does show promise with non-expert use when it's associated with tailored training. And that is about it. Just for acknowledgements, I just want to acknowledge Krista Swisher, who's done a lot of great work about this, and she's published some really fantastic papers. Sue Herman, who got me interested in this whole quantitative EEG thing to begin with, and the whole epilepsy division at BI and Harvard where I trained. So thank you.
Wonderful. Thank you very much. That was very thorough. Great talk. So we had a couple questions come in, and one of them, so I try to answer the ones that are about PERSIST itself. I can answer those, and I just want to reiterate, several people were asking that the seizure detector algorithm within PERSIST is proprietary, and the algorithm isn't found outside of the software itself. So I just thought I would mention that since we had a couple questions on that. And then we had questions about QEEG. It seems, let's see, so one person wants to know about using QEEG, specifically power spectrum or frequency spectrum over a certain channel, and how this could benefit clinically, or is it only for research work? Now, I know you covered a little bit of that in your talk, so maybe you could just expand a little bit.
Yes, so you can look at a lot of the trends I discussed over a particular channel, and you can actually even create customized envelopes. So I think the first PERSIST rounds talked about how to set up customized detections. So you can do that if you have a certain pattern you're looking for a given patient. But yes, you can, besides just kind of the default view I was showing you with the rhythmicity and the FFT or color density spectral array, you can further subdivide that in terms of looking at each individual channel. And that can be helpful both clinically and has utility in research too.
Great, thank you. We actually had a comment just come in that could be useful. As a comment, the rhythmicity spectrogram can be made more useful when individualized for each patient by resetting the y-axis from the default of 1 to 25 Hertz to match the predominant frequencies encountered in a patient's seizure, such as if seizures only evolve in delta theta range, then the rhythmicity spectrogram can be readjusted to a more sensical range, which will more clearly show the evolution diagonal slope of rhythmicity. Yes,
Right.
thank you. That's a very useful comment.
Absolutely.
Yeah. Okay, and then this question came up during when you were speaking about the publications and the validation studies, so I'm thinking that it's about that. The question is from Barbara Wine: do they take into consideration clinically what is happening to the patient, and do they evaluate it for pseudo seizures?
Yes, so to answer the second part first, they evaluate for pseudo seizures. I don't think there's actually much in the literature about looking at pseudo seizures. Part of that is because a lot of the studies for quantitative EEG are retrospective. So they're kind of selecting for patients who already have had real seizures. So it's kind of more of a selected population, but I think that's definitely a really useful area to look at. Like, what is the false detection rate for pseudo seizures, and what are the different factors that can go into it? Because I know anecdotally, I have seen, of course, false detection with that. Like if there's a lot of movement artifacts, for example. Do they take into consideration clinically what's happened to the patient? Yes, so some studies are looking at more seizures that had clinical changes, but most, I think, we're focused on electrographic seizures, which may or may not have clinical correlation. So a lot of what I've seen in literature and what's been published has been more so like electrographic seizures, and kind of then subsequently seeing there. I don't really know how often there's a clinical association.
Great. Okay. All right. Do you have examples of the more common false alarm patterns, both automated and non-expert in origin, and their more frequent causative phenomenon, i.e. ventilators, soothing movements, etc.?
Yeah, it's a good point. I don't have any slides of that now, though. I have a huge collection of false detections in my or I have a huge thing I've collected, just different raw EEG patterns. But definitely there's a lot of these artifacts that can be messed up, which is one of the reasons why I think we need more studies about QEEG in the ICU population, because in the ICU population, we have ventilator artifacts, other devices, things like that. So
right, a lot more confounding variables found in that environment. Yeah. Okay, great. I don't see any more questions. There is a second comment from the first commenter. The rhythmicity spectrogram can help with identifying evolving, fluctuating periodic patterns, as these patterns usually will present in the rhythmicity spectrogram in the 1 to 4 Hertz range. So when that is an important goal for me, I adjust y-axis to 1 to 5 Hertz, and then clearly see when the periodic pattern is worsening or fluctuating on the ictal-interictal continuum. Again,
exactly.
Great comment. Yes, thank you very much. Okay.
And that will make it pop out more, exactly. As you said, it makes it pop out more if you adjust that y-axis. So when you're flipping through in the 2-hour epochs, you can really see it jump out more.
Yeah, and I think that's a really important point, that if you adjust the parameters within the trends, that it really can help make it more effective for your individual patient if you know what range their seizures are happening in. So yeah, these are great comments. Okay, another question here. Earlier it was mentioned that it is needed to know the EEG signature for each patient. What would this signature entail, and what would be noticeably changing from patient to patient?
Yeah, so what I mean by that is once you have seen a patient have a seizure on the raw EEG, what I suggest is having that side by side with the quantitative EEG and say, okay, what does this seizure look like on the raw EEG? So what was detected by the seizure algorithm? Does it light up on maybe the rhythmicity spectrogram or the FFT or the amplitude integrated EEG or the asymmetry index? So you kind of look at that raw seizure side by side with the quantitative EEG and then note what parts of it pop out, what is highlighted from it. And then what you can do is you can then subsequently look at EEG in the future for that person and see if you ever see that same pattern pop up. So in the talk, I was kind of trying to emphasize that for certain patients, certain seizures would show up under certain modalities. So for example, the more classic seizures that show evolution in multiple modalities, frequency, spatial temporally, those are going to be really well detected by the standard seizure algorithm. However, some patients maybe with more isolated focal seizures that don't really evolve well, those might be better for asymmetry. Focal with generalization might be good for rhythmicity or color density spectral array. So it kind of depends on each patient's EEG evolution pattern.
Yes, that's an important point, that you learn what the signature is in the trends by looking at the raw EEG. Once you understand the nature of that patient's seizure types in the raw EEG, you assess what it looks like in the trends, and then that becomes your fingerprint for going forward and looking for more.
Exactly.
Yeah, great. Great, thank you. Okay, the same person who's commenting, I'll just try to say the name, I hope I don't say it incorrectly. Abdullah Al-Shama was the wonderful commenter before, and now they are saying that the versus baseline spectrogram can be helpful for really focal, limited spread and low amplitude seizures, specifically when looking at the trend that shows each of the 4 quadrants separately and setting the baseline strategically. Another great point, the versus baseline spectrogram is relatively new within PERSIST, and it allows the user to define a period of baseline within the EEG. So for example, when your patient first is admitted to the hospital, for example, you set a baseline, and then you're able to see changes from that baseline statistically measured in Z-scores, and it looks at statistically significant decreases and also increases in activity compared to that baseline. So that's another great point. Okay, so I think that is all the questions we have for today. And I want to thank you again, Dr. Casassa. It really was a pleasure. I think these are some really important points that you went over. There's a lot of questions around how to use quantitative EEG trending for non-neurophysiologists, and the basics of what you went over as well in the beginning were really helpful. So I want to thank you once again. It really is a service to the community, and we're thankful for every speaker that donates their time. So we'll end it there, and thank you again.
Thank you. It was a pleasure.
All right. Bye, everybody.